On Talking with Dr. Donna, we focus on 4 pillars of health to help build a generational health network to end the cycle of premature death in the Black community. I created Talking with Dr. Donna as a way to educate as many people as possible and give accurate information from a trusted physician. Go to Talking with Dr. Donna and get accurate information. And then share that information with your family and friends. And if you like what you see, like my channel and subscribe. Remember, every Thursday, keep your appointment with Dr. Donna. Hi, good evening, everyone. Welcome to another episode of Talking with Dr. Donna. I am Dr. Donna White-Carey. I am the host of this show, and this show is for you. This is for your family. And my purpose in bringing these episodes to you is because I want to build generational health for you and your family, starting right now, so that we don't continue to have incidents of high blood pressure, cardiac disease, diabetes, obesity, cancer rates that are higher than other communities. So we're going to build generational wealth starting right now, generational health starting right now, right where we are. So today we are talking about heart health. And let me tell you why heart health is so important for our community. Number one, it is the #1 cause of death across the United States for all ethnic groups, okay? Heart disease is the #1 cause of death. And we know in the African American community that there's like an 8 to 15% higher rate and incidence of heart disease than it is in other communities. So this is an important topic. And today I have a great guest, a dear friend of mine, a practicing cardiologist here in Oakland, who has really devoted his life to making sure that we survive heart disease, but more important, that we prevent it from happening in the first place. We're going to talk tonight about just your general heart health, and then we're going to talk about a couple of different diseases. So we're going to talk about having a heart attack, we're going to talk about atrial fibrillation, and we're going to talk about strokes. We're not going to get into details and too much details into any of these things individually, but it will be a great foundation. And in subsequent episodes, we will dig deeper into each of these topics individually. So I want to bring in my friend, Dr. Rollington Ferguson, cardiologist. And Dr. Ferguson hails from the Bahamas, one of my favorite places. And hi, Dr. Ferguson. So I'm just going to give a bit of background about who you are, and then you and I are going to get into this discussion about having healthy hearts. So Dr. Ferguson is from the Bahamas. He has been in the Oakland community for a number of years. He has been a previous president of Sinclair Miller Medical Association. And for those of you who are not familiar with Sinclair Miller, that is the Medical Association of African American Physicians in the Bay Area. He also is on the board of governors for Alameda Alliance, which is the insurer for Medi-Cal in our county. That's our county health insurer. And he's also on the governor's board for the Alameda Contra Costa Medical Association, also known as the ACCMA. So welcome, Dr. Ferguson. We're going to unmute your mic. Go ahead, Raleigh. Let's see if we can hear you.
Thank you. Can you hear me okay now?
Yes, we can.
Good.
Awesome. Thanks for being here.
Okay, thanks for having me.
You're welcome. So, you know, we always, as African-American physicians, I know a lot of people always say, well, where did you go to school? So let me give some of your credentials, Dr. Ferguson, okay? So he attended college at what is now Minnesota State University. He got his master's in public health at UCLA, yes, my alma mater. Received his medical doctorate degree in the UCLA Drew program, moved up here to the Bay Area, did his internal medicine residency at Highland Hospital, and then did his cardiology fellowship at University of California, San Francisco. So very well educated, and I'm happy to call you my friend, Dr. Ferguson.
Thank you. Thank you.
All right, so let's get into it. So we know that heart disease is the #1 killer in the United States.
Yes.
Yes. So can you tell us, like, why do you think it's so prevalent?
All right. So in general, there are traditional risk factors for coronary artery disease and heart disease. So when you talk about heart disease, of course, it's a lot of different diseases that you're talking about. So when you talk about heart disease, you can talk about blockage in the arteries that result from high cholesterol, diabetes, etc. So there's blockage in the arteries, and when that happens, um, that results in a heart attack. So when you let me just talk a little bit about different types of heart disease, right? So when we're talking about heart disease, um, you can talk about blockage in the arteries, okay? And then that's one part of stuff that we look at. And then you can actually talk about diseases involving the heart muscle itself, okay? And in addition to heart muscle, you have the valves, okay? So you can talk about the um, problems with the valve. And then finally, there's problems with the electrical system. So when you talk about heart disease generically, it's really a broad range of disease that we're talking about. Now, most commonly, we have coronary artery disease, which is blockage in the arteries. And these are the ones that traditional risk factors play a significant role in. Cigarette smoking, diabetes, high blood pressure, lack of exercise, obesity, okay? And it's all these things that contribute to coronary artery disease or blockage in the arteries and heart attacks. Um, on the other hand, especially in the African American community, one of the other disease that we have is simply hypertensive heart disease, right? And in hypertensive heart disease, what we see are several stages. If you can look here, this is the wall of the heart, and with high blood pressure that's untreated, the wall of the heart kind of thickens. We call it left ventricular hypertrophy, and at some point, the ventricle, that's the cavity of the heart, dilates, becomes inefficient, and patients develop symptoms of congestion. So, to your original question, why do we have so much heart disease? Risk factors: diabetes, high blood pressure, obesity, okay, lack of exercise, diet, those type of things.
Yes, thank you, Ron. I love that you brought your heart and that you gave us all of the different types of heart disease because, like you said, it is a catch all phrase.
Right.
So it's nice to understand that the various types of disease of your heart that can happen. So thank you so much for that. Just a quick note to those watching. Tonight, we are going to try something a little different, which is to try to answer some questions live at the end of our show. So if you have any questions, right now, you can type them into the comment section and we'll attempt to get to at least a few of those questions before the end of the show. So just wanted to make sure we do that. Okay, so you talked about generically all of the different diseases that we can have with heart disease, and we say that. One type of heart disease that I feel like is getting a lot more attention in the press, and I don't know if that's because we're seeing a lot more or if it's because people are just more aware of it, but that's atrial fibrillation. Can you talk a bit about like what atrial fibrillation is? If you have a question for Dr. Donna, please do leave it on my page and I will be happy. Ignore that my video is playing in the back.
Okay, okay. So basically, what happens in the normal heartbeat? The normal heartbeat, the beat is very regular. It starts in the right upper chamber of the heart, and basically, it's very regular. Okay. The next thing that you have to realize in atrial fibrillation, what we have is an irregular irregular heartbeat, and it's kind of really chaotic. So the beat in atrial fibrillation does not come from the normal sinus impulse. It comes from the atria instead, and as a consequence, it is very irregular. And so, um, for the audience out there, if I can kind of simulate the normal heartbeat is doop doop, doop doop, doop doop, doop doop, and it's very regular. And in atrial fibrillation, it's just all over the place. So in atrial fibrillation, you have doop doop, doop 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 doop, doop doop, doop doop, doop 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 doop. Okay, so
Wow.
it's kind of all over the place. Okay, now what happens in atrial fibrillation? There are a couple of things that happen. One is ultimately the atria enlarges. Okay, that's the top chamber of the heart. It enlarges, and clots form in the top part of the heart. Okay, and these clots, the significance of this is that the clots can then go off to the brain and result in strokes. Okay, so that's the one of the main issues with atrial fibrillation. The other issue is that as the heart itself enlarges, right, the top part, and ultimately other findings of congestive heart failure, the the top part of the heart basically normally gives an extra kick to pump the blood out, through the ventricle, um, to the lungs and the rest of the body, depending on which ventricle we're talking about. Well, in atrial fibrillation, that we lose that extra kick, so to speak, and as a result, some patients are more likely to go into heart failure with atrial fibrillation. Okay. Now, um, is there more of an increase in atrial fibrillation? Um, I have not looked at the recent um, rates or incidents per se. However, one of the things that comes about with um, disease, is that as you get more treatment available, there's
Mm.
more talk about it. So one of the things is there's a lot more treatment that's available for atrial fibrillation. Previously, what we relied on is simply first aspirin, and then the question was one of Coumadin, or warfarin, to treat atrial fibrillation. And so those were the medical ways to actually simply prevent stroke. And then later on, we progressed to a stage where one started talking about whether we should control the rate in atrial fibrillation or try to convert to a normal sinus rhythm once again.
Mhm.
So as we went through these different changes, more medication, more device therapies, more options that became available, there is more talk about it and you hear more in the media about it, but I am unclear of the actual incidence in disease. And I suspect a lot more of the talk is due to the new therapies that are available.
Great. That's awesome. I want to back up a little bit because I realize we're talking about atria and ventricles. And I'm not quite sure if the audience out there knows the difference between that and how the heart is actually structured. So, can you just go through that?
Yeah, so basically, the heart has four main chambers. The way I like to describe it is it has two upstairs chambers and two downstairs chambers. The upstairs chambers, which are above the ventricle, so A for above, is atria, and the lower chambers are called ventricles. Okay, and basically, um, the ventricles are the ones that really do most of the work. So that's why they're more muscular, essentially, than the atria. So the lower chambers ventricle, um, upper chambers atria, for a wall down the middle that divides the chambers, and a horizontal wall across, or essentially you can look at it as a wall to visualize it. Does that make sense?
Yeah, no, that's perfect.
Okay.
Exactly. Perfect. I love your A for above. That's awesome.
Okay.
All right. So let's move into now talking a little bit about stroke. We mentioned it earlier, and we talked about it being could be a result of having untreated atrial fibrillation. Then we talk about what a little bit more of what happens in having a stroke, um,
Yes.
how the heart is involved with that. So just, guy, take us through that.
Yeah. So, um, think of a stroke as a heart attack to the brain. So a brain attack. Okay. So as we mentioned before, there are arteries to the heart and they run on top of the heart. There are two main arteries, right? And if one of those get blocked, it results in a heart attack somewhere. Okay. Well, similarly, you have blood vessels going to the brain. Okay. They're called the carotids, and then they go, well, the front ones are carotids, and then the back you have vertebral. But basically, there's blockage in one of the smaller vessels. Um, that results in a stroke. So the same way, if you can imagine a hose, basically you're taking water in a hose, and if the hose gets blocked off, water is not going to go. Well, blood flow, if the blood flow to the brain gets blocked off, it's going to result in a heart attack. So there are a lot of things that can do this, right? You can have embolic phenomenon, which is basically a clot going to the brain. And in the case of atrial fibrillation, there's simply a clot that's sitting there on the left side of the heart in the upstairs chamber, the atria, and that goes off to the major blood vessel and into the brain, and it can cause a stroke. So that's one type of stroke. The other type that you can have is simply a hypertensive stroke from uncontrolled blood pressure. So you can have different forms of stroke, but commonly we're seeing a lot of what we call embolic stroke these days. And embolic basically means that it's a blood clot forming from somewhere else and going to the brain.
All right, thank you for that. What are, I know there's an acronym called FAST for the symptoms of a stroke, and how people can recognize when they're having a stroke and what they should do if they think they're having a stroke or if one of their loved ones is having a stroke. What
You
do you
know,
think about that acronym? Do you like it?
uh, I'd rather simplify things. What I'd like to say to people in recognizing a stroke, okay? Um, if think of it, you have two hands, two eyes, everything symmetrical, okay? Um, if you got symptoms, if one hand became weak, one finger became weak, okay? So usually a stroke is one side or the other, okay? So you just think, all of a sudden, all of a sudden, I'm having numbness in the one hand, the right hand, say, okay? Um, that's a sign of a stroke. The right foot, right? The left foot, okay? Um, think of speech, right? All of a sudden you're numbing your words. Once all of a sudden you're having visual difficulty in one eye versus the other. So what I like to tell folks is to think of one-sided stuff, okay? Think of stuff that's normally working on two sides, and then all of a sudden it's one side. Now, don't get me wrong. You can have um, um, both sides involvement. With a large bleed inside the brain, you can have um, both hemispheres involved, right? But again, um, what my my thinking really is that is much rarer, and so just to look at the unilateral signs, I think for the common folks, just to think of unilateral. Does it move like it's supposed to? Is it numb like it's supposed to? Is it numbness? Is there a difference in speech? Is there stuttering? Any of those kind of things, I think, is a better way to.
Yeah, so that's great. So if you normally have functioning same size, both sides function well. You normally don't have numbness or tingling. You normally are not weak on one side. You normally can smile fully. And
That's
then
right.
all of a sudden, you can't.
That's right.
Then you want to make sure you call 911. Why is it so important as soon as you recognize that something may be a little off to call 911 and not to wait?
Yes. So almost everything we do in medicine depends on how rapidly you get diagnosed. The treatment options that are available um, um, basically depends on getting there in the first 4 to 6 hours. Heart attacks, strokes, same thing. So um, the minute you realize that there's numbness, weakness on any single side, um, um, then to think that it might be a stroke. And I carry um, this concept of two-sidedness a little bit further. Okay. So one of the questions that always come about is, um, do you know do I have a blood clot in my leg? All right. So some of my patients get swelling in both legs, and they call and they say, I'm having swelling in both legs, right? And um, I basically, you know, say it's unlikely to be a blood clot if it's swelling in that case. It could be heart failure, and it could be kidney, and it could be liver and all that. But when they tell me that, you know, hey, one side of my leg is a lot more swollen than the other side. Again, it's different. So there's a difference in this one side than the other. And for most patients, you can look down on your leg and see that there's a difference, right? And so if there's a swelling on the one side and there's no swelling on the other side, then you start to think, oh, this could be a blood clot on the one side. So I think the concept of looking and feeling what's going on with your body um, is critically important.
That's great. I think that's so important because one of the things that I like to tell people is that you really need to know what's normal for you. And when you
Right,
can recognize what's normal for you, then when something happens, you know immediately that that's not quite right. That's not how my body operates. And then that's when you should seek the care of a doctor.
right.
So let's talk a little bit about heart disease in African American community. Anything different about the disease in our community, or any advice, tips for African American patients to how we can take care of our hearts better?
Yeah. Okay. Um, there 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 are a couple of things. Um, I think we as African Americans need to pay attention to our blood pressure. Okay. Quite naturally, we tend to have higher blood pressure, and not to be um, worried about the blood pressure as much. So we need to know our numbers. We need to know what the numbers are for the risk factors that we talked about. Okay. Um, I have patients that have high blood pressure, um, and some come in and say, "Oh, I don't take my medicine because I didn't feel anything." Okay, and what I try to point out is that by the time you feel anything, it's almost too late, right? Because that's why they call it the silent killer, right?
Right.
Um, basically, um, you need to know your numbers and stay control. Um, so blood pressure is important. You need to know about your salt intake, okay?
Mhm.
Again, because salt intake is gonna increase the blood pressure. I have a few again patients who say, "Oh, I don't use that. uh, regular salt, I can use sea salt. Okay. Well, sea salt is the same as, regular salt.
Right.
Okay. So you have to watch your salt. You have to watch your diet. You know, um, a lot of guys come in and they say, "Oh, um, um, it's gonna affect my nature."
Hmm.
Um, I'm not gonna take that medication because it's gonna affect my nature. What? I mean, it's more likely that your nature's gonna be affected than by the blood pressure and the diabetes and the high cholesterol than the medication. So, you just need to modify the risk factors, pay attention in our community. We need to exercise. You mentioned um, 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 you got me off on a tangent a little bit here when you said African Americans. I had a brother come in the other day, and he was sporting his shirt "Black Lives Matter." Okay, and and then he told me, he's got hypertension, and he says, um, you know, I just quit taking my medication. And you're telling me Black Lives Matter and your own life doesn't matter because you're not taking your medication. So
Yeah.
if Black Lives Matter, okay, it's not just the social justice aspect of it from the law enforcement or whatever. If Black Lives Matter, then it matters about taking care of yourself. It matters about your health, and watching your blood pressure and, eating the right food and exercising, you know. So um yes, Black Lives Matter, but we have to take care of ourselves. We have to watch those risk factors that we're talking about, and we have to take our medications.
Yeah, thank you. I'm so glad that you said that because it is important. And that is one of the reasons why I have this show, and it's talking about generational health. And some of our, habits and things that we learn from previous generations, right? We learn from our mothers and, or, parents and grandparents, and how they thought about their medication and how they thought about their disease then moves into the next generation and how they think about the disease. And so I'm on a mission to really stop that so that, as you say, all lives matter, Black lives matter, your life matters. So you have to take the medication as prescribed
That's
by your
right.
doctor and not stop it because you feel good.
That's right.
Because oftentimes you can't go by just how you're feeling because things are happening on the inside.
Hmm.
I know there have been lots of changes in the number that we should be looking for a good blood pressure. What's the latest now? What's a good blood pressure? What's a normal blood pressure?
Okay, so it's gonna depend on if you have diabetes or other risk factors. But in general, we're still looking at the lower than 140 range for the systolic, and lower than 80 range, 60 to 80 for most people. For diabetics, those numbers go a lot lower. They go into the 120s in the top number and 60s or so in
Wow.
the diastolic. And I think those are like really, really hard criteria personally. But because once you have diabetes, um the risk is of developing coronary artery disease, blockage in the arteries, is so high that you want to do everything to lower your risk. And that means lowering the blood pressure even more.
Wow. So I want to be very careful with our doctor speak. I know systolic and diastolic, I understand, but I want to make sure that our listeners understand. So can you describe what
Yeah,
is systolic, what is diastolic?
yeah. So basically, the way to think of it is just the top number we're looking at is the systolic blood pressure, and the lower number is the diastolic blood pressure. So if you have um your um sphygmomanometer at home and you're trying to figure out which number we're talking about. The the big number, the top number, is the blood pressure that we're talking about in systole.
All right. Can you maybe also explain a little bit about what does it mean to have a systolic? What does that actually translate into the heart? And then
Yeah.
diastolic, how does that
So the
translate?
systolic blood pressure. So, oh, did I lose you?
No, I can see you.
Oh,
Can you
um,
see me?
no, I can't. Something happened. But the systolic blood pressure, if you can still see me, basically refers to the number that happens when the heart contracts. So there's there's the heart has two components of it. There's a contraction and there's a relaxation portion. So diastole refers to the relaxation part of it. The systolic is the contractile force that's generated. Also, and the systolic blood pressure is going to depend on the elasticity of the artery, how hard the artery is. And so that's why, especially as you get older, you see something called isolated systolic hypertension, which is more related to hardening of the arteries. But the main thing that you are thinking about in systole versus diastole is systole contraction and diastole relaxation. Um, um, can you see me? I don't have an image here.
Yeah, I'm seeing you perfectly.
Oh, back. Thank you. Okay. All right. You know, this Zoom thing, this is new to me. I took
I
20, 30 minutes before the show just trying to figure out hook it up here. So there
You're
we
doing
go.
great. I can see you and you're giving us so much valuable information. This is awesome. So thank you. I want to talk a little bit about blood pressure medication because so many people, there's so many different types of medications. And, are there types of medications that you think work better for African American patients than other types of medication, or pretty much anything?
So,
I know that's a hard question because it really depends on other risk factors and what else
right,
is going on.
right. So with that caveat that it does depend on other things that's going on. Um, one of the um, there are four traditional classes that you like to think about. Calcium channel blockers, diuretics, beta blockers, ACE inhibitors. Now, um, in the past, um, folks basically said that um, African Americans were better with diuretics. Okay, um, so diuretics is what a lot of our folks call water pills.
Yes.
Okay, and the reason was basically felt that the blood pressure in some ways was related to volume expansion. In other words, too much fluid in the system. Okay, so that's a simplistic way of looking at it. And so if you reduce the intravascular volume, you lower the blood pressure. So a lot of folks felt diuretics work really well in African Americans because of that. Um, and so for generations, that's been the choice of medications for um, African Americans. Personally, um, I I use diuretics only sparingly and rarely. One of the things is um, one of you know when we're lowering blood pressure, we're not lowering just to lower it. We're lowering it to reduce um, um, different disease. So when we lower blood pressure, it's because we want to reduce stroke. It's because we want to reduce coronary artery disease. It's because we want to reduce end-stage renal disease and people ending up on dialysis. Well, it's my opinion, I think, that diuretics don't really reduce the the number of African Americans ending up with end-stage renal disease. And
Mm.
in fact, I think that, it may contribute to it. In either case, because of that, diuretics is not my um, favorite, even though that has been the long-standing teaching. And I prefer starting African Americans with a calcium channel blocker. Calcium channel blockers as a class are effective in all groups of people, whites, older patient, African Americans. So it's pretty effective. Now, um, beta blockers and ACE inhibitors are the other two classes of medications. Again, as a rule in general, they're less effective in
Mm.
folks who simply have hypertension. However, if you have heart disease already, then you definitely need a beta blocker and an ACE inhibitor. If you have a weak heart, if you have hypertensive heart disease, folks with beta blockers live longer and do better. So even though it's less effective, um, in certain disease condition, um, it's better to use those medications. One of the interesting things that's going about right now is with COVID-19. And with COVID-19, the um, the coronavirus that causes uh, the COVID-19 disease basically attacks the lungs through the receptors called the ACE receptors. Those are the same receptors um, that the medication work on. And so there's been some studies, or at least case control studies, to say, hey, um, should these people be taking ACE inhibitors? Okay.
Mm.
And I think the preliminary data suggests that patients should still continue taking their ACE inhibitors, even though they may be at risk for um, coronavirus. Now, it's actually kind of an interesting question, because most African Americans, I think, who um, um, simply have high blood pressure and don't have congestive heart failure or coronary artery disease. I think most of them are not on ACE inhibitors. And as you very well know, most um, the highest incidence of um, coronavirus disease is in African American, of course. And so one of the questions I would like to have answered is that ACE inhibitors actually protective um and in certain groups, rather than just having no effect at all? And could it be that um because there are less African Americans on um on ACE, that this is a contributing factor? That's totally speculative, totally um, not factual, what I just said. Simply just speculative at this
Yeah.
point. Okay.
Wow, but that's great because it leads us right into what I wanted to talk about in our last bit of time is coronavirus, and how what it does to the cardiovascular system. And I heard some reports and read some studies that said, the 30 to 50-year-old age group they were noticing that they were having strokes. And one of the thoughts was that potentially they were being caused by coronavirus. What do you think about that? Or do you agree, disagree, or have you heard that?
Okay, so there are a couple of things that um, seems to be happening in terms of the cardiovascular system with coronavirus. Okay. Um, so recall that um, when we one of the things that we talked about, for example, is the was the musculature of the heart. Okay, so coronavirus does seem to affect the musculature, causing something called myocarditis, which is basically an inflammation of the heart muscle wall. Okay. The other thing that we see in coronavirus is that when you go into the hospital and you have chest pain, for example, or shortness of breath, or anything to suggest that you might be having a heart attack, one of the things that we do is an enzyme called troponin, and if the troponin I especially is elevated, then that gives us an indication that um, there there might be a heart attack, that at some level that there is heart muscle damage. Okay. And so in coronavirus patients, we're seeing elevation in this troponin I.
Hmm.
Okay. And so it implies that there's some damage to the heart muscle. Now, one of the interesting things is that when um, when you go in to do a heart catheterization, that's where you go in with the catheters and look into the blood vessels of the heart to see if there's an actual blockage. They're finding that there is not any significantly increased blockage in the case of those positive troponin I. Now, so that's one of the things that we're seeing. Now, I want to come back around to your question about the increased stroke a little bit. Um, One of the things um, that you're seeing in the coronavirus is an increased thrombotic potential.
Mhm.
All I'm saying there is that there's increased chance of blood clots. Okay, so um, earlier we talked about atrial fibrillation
Okay.
and how blood clots form in the top upstairs part of the heart, the left atria, and could
Mhm.
then go to the brain and cause a stroke. Well, basically, if blood clots are forming anywhere in the systemic part of things, in the arteries, and again, it goes off to the brain, you can have a stroke. So it is possible that we will be seeing more strokes, more central effects, I think, as related to coronavirus.
Wow. Wow, that's kind of scary.
It, it is scary, um, it is scary um, from several perspectives. Um, um, because folks keep talking about a vaccine, but
Mhm.
even if there's a vaccine and there isn't any real cure, a lot of people are still gonna get sick from the disease. Okay. um One of the things that you know um we've seen a spike in cases here in Alameda County, of course.
Mhm.
And one of the things, I walk around the lake, and again, this goes back to my Black Lives Matter thing. And,
Yes.
I see all these young African Americans who, and I'm picking on African Americans because that's me,
Yes.
and that's what this show is about.
Yes,
Okay.
absolutely.
Okay. But they're all out there not wearing masks, not maintaining social distance.
Yeah.
Okay, it's they walk around with impunity as if this disease will not affect them.
Yeah.
Okay, but they may walk with impunity, I think, but they're not immune.
Right.
Okay, they're not immune, and even though they may be healthier carriers, um, they're going to pass the disease on to their grandparents, their loved ones, someone else. Um, so, 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 I would say drop that impunity and start to wear masks and start to social distance because, you know, it. this disease is serious, and it is taking out young people, and it is taking out old folks, and we all need to do our part, um, um, with regards to um, saving lives.
Yeah.
Um, so there are other various parts, uh, uh, um, you know, or of the heart that coronavirus seems to affect. There are some studies that seem to show that the right side of the heart um, enlarges the right-sided pressures, and the pressure inside the heart
Mm.
tend to go up, with the corona disease. Um, there is some suggestion that we're seeing more Takotsubo kind of disease, and Takotsubo is basically um, um, the disease that we call broken heart syndrome. So if you've heard of the broken heart syndrome, it's the Takotsubo, it's catecholamine excess, etc., leading to this disease. So we're seeing various manifestations of corona in the heart. Okay.
Wow. Wow. Well, thank you, Dr. Ferguson. I don't want to call you by your first name. So thank you, Dr. Ferguson. I think this is a great place to pause and see if there were any questions. Again, if you joined us late, we are going to take a few questions live. So if you have any questions, you can type them into the comment section and we will attempt to answer a few questions. So I'm going to look over to my assistant to see if anyone has any questions in the chat. Yes. What's the question? Go ahead.
Okay. What can we do to hold off or avoid embolic strokes in regards to our lifestyle?
All right. So I think you kind of touched on this a little bit already, but the question is, how can you avoid getting a stroke, or what other lifestyle changes? You talked about exercise, diet, controlling blood pressure, making sure if you have diabetes, that's under control.
And
Anything else you want to add? High cholesterol?
right. And those are the main things that you consider. So it's all kind of lifestyle choices. I didn't talk about family history as well, which is a contributing factor.
Yeah.
So family history contributes to coronary artery disease, hypertension, possible types of stroke, but there's nothing you can do about family history. But the stuff that you can do things about is all the personal stuff, the lifestyle stuff, the controlling blood pressure and all that. So I think those are the main impacts that you can have, not just on stroke, but on heart disease in general.
Right. And that is why I'm focusing on generational health, because you can't, if you start now, and in our generation, if we treat our bodies well and we decrease the incidence of diabetes and heart disease for ourselves, then that also helps the future generations because they have a leg up on starting to be healthier. So
Yeah,
thank you.
can I just comment on
Yes,
that?
absolutely.
You keep on mentioning the word generational, and I think that's really important. One of the things is I'm a member of this group called the ABC, and the ABC is the Association of Black Cardiologists, and the the motto of the one of the motto that we've adopted is that children should get to know their grandparents.
Yeah.
Okay, all right. Um, and what that is saying is basically that not just the younger generation, but you need to take care of that older generation so that the kids grow up to know that generation. And
Yeah.
how do you do that? Once again, by reducing the disease in this group of patients.
Yes. Thank you. All right. My assistant, who is my lovely teenage daughter, Trinity. Okay, you have another question?
Yes. Is Pradoxa meroprolo
Uh-oh. Spell it.
MEROPROLOL.
Sounds like metropolol.
Whatever it
No,
is.
Okay.
spell it again. What
Spell it
does
again.
MERO.
Oh, MERO.
PROLOL.
metoprolol? It spells a little wrong there,
Yeah,
but it's
yeah, but it's
metoprolol.
metoprolol. Okay,
Yeah.
what about metoprolol?
And Lipitor, are they right medicines to be on after a stroke?
Okay, so metoprolol and Lipitor, are those good medications to be on after a stroke?
The
Probably a tough question because so many factors, right? But
no, we can answer it.
okay,
The Lipitor is definitely a good medication to be on after a stroke, and the beta blocker metoprolol is a good choice as well. Um, Again, there are other things that one need to take into account, but metoprolol, um, there are two forms of metoprolol, and and the there's a short acting kind called metoprolol tartrate, and there's a longer acting metoprolol succinate. And the succinate may be a little bit better than the tartrate in some instances. Um, but those are good choices for medications. Again, with each patient, you have to treat each patient differently.
yeah,
Um, if I have a young guy that comes in and and you know and one of the things is metoprolol can affect um, um, erectile function or to some extent, right? So that's not going to be my first
mm,
choice for giving a young guy because I already know he does not want to take a blood pressure medication, and to give him something that is going to affect his sexual life, you know, that and there's a substitute, something else you could use, I wouldn't use it. So it depends on um the instance. Again, if it was someone with coronary artery disease, um, would definitely be like a first choice. So there are a lot of factors to take into account, but again, um, as a medication, um, absolutely yes, I would
all
give it
right,
to someone. Okay.
great, thank you. Other questions? Go ahead, quickly,
Should
please.
one be terribly concerned about palpitations or flutters?
Did you hear that question,
Yeah.
Dr. Ferguson?
Yes. Yes.
Okay.
Okay. So um, again, palpitations is more a subjective feeling. Okay, palpitations and flutter, and it should be investigated. You know, people feel, palpitations is basically what you're feeling. Your heart seems to be racing or irregular or whatever, and so it's better to have an evaluation. I would say yes, to be somewhat concerned and have it checked out, but it does not necessarily mean anything. For example, um, caffeine, exercise, anything that stimulates can cause like an irregular heartbeat, right? And that is perceived as palpitations. On the other hand, atrial fibrillation is also perceived as palpitations or flutter, okay? Um, and then on the other side of it, um, in females, like most men, have traditional symptoms of coronary artery disease, of having a heart attack. And men, for example, have, substernal pain under the chest, going down the arm, going up the jaw. Women may just have palpitations or flutter, or just a little shortness of breath. So it really depends on the patient. And so because of that, of all the things that it could represent, I would say yes, it should be concerning,
Great.
but not necessarily alarming. Okay, concerned but not alarmed.
Concerned, but not alarmed. Okay, great. Other questions?
Yes.
Go ahead.
Read it, please. In the event of a stroke, is there a critical timeline in order to get emergency treatment?
Yes, 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 yes. That's what we're saying.
Yes.
Sooner the better. The minute you feel symptoms, and that's why I talk about the focality or the one-sidedness of things, is because the minute you start to feel symptoms, you need to run in there. There are treatment options. There are blood thinners that is not available after a certain time. There are things that you do within the first 2 to 6 hours that you're not going to do much later.
Great. All right. Any other questions? No other questions? Okay, great. All right, Dr. Ferguson, any last comments? Anything you'd like to leave us with that we didn't discuss or you want to expound on?
You know, I guess 3 summary points, or 2 summary points, I would say. One is reduce your risk factors, right? Control your diabetes, control your blood pressure, control your cholesterol, exercise, okay, reduce heart disease and strokes. That way, take your blood pressure medication. And then on the note of Black Lives Matter, yes, Black Lives Matter. Again, take your medication. When you're out and about, you're you're not immune, so stop the impunity, wear a mask, do safe distancing, and Black Lives Matter in all our communities. So think of that person as your brother, your sister, and I mean that at every level, every socioeconomic level that you can think of. If you really believe that statement, if that is, something that you're gonna wear on your shoulder, around your neck, then it doesn't just apply when when it's another race that's taking advantage. It applies in the way that you treat yourself, the way that you treat your brother and your sister, that we are our brother's keepers. That's it.
All right. Well, I think that's an excellent place to start. I want to thank my guest, Dr. Rollington Ferguson, a cardiologist here in Oakland, California. That's it. This is Talking with Dr. Donna. Thank you for tuning in. And just remember, every Thursday at 6 p.m., you have an appointment with the doctor. So we'll see you next week. Take care.
Thank you. Bye-bye.
Thank you, Dr. Ferguson.
Thank you.
On Talking with Dr. Donna, we focus on 4 pillars of health to help build a generational health network to end the cycle of premature death in the Black community. I created Talking with Dr. Donna as a way to educate as many people as possible and give accurate information from a trusted physician. Go to Talking with Dr. Donna and get accurate information. And then share that information with your family and friends. And if you like what you see, like my channel and subscribe. Remember, every Thursday, keep your